Good morning. Thank you all for joining the AI Assistant in Hemodynamic and Respiratory Management in the ICU webinar, jointly hosted by Radiometer and Etiometry. My name is Anthony D'Angelo. I'm a Senior Product Manager for Radiometer's Digital Solutions, and I'm honored to be the facilitator for this session today. We're driving into specifics about how advanced data aggregation, visualization, and risk analytics have been employed to support important critical care workflows. This conversation continues to gain relevance as ICUs evolve in complexity, acuity, and data availability. We're privileged to be joined by two esteemed speakers who have extensive experience with the Etiometry platform and who have authored peer-reviewed articles studying its associations with important outcomes. To get an introduction of the Etiometry platform and its clinical applications, such as extubation readiness and vasoactive weaning workflows, we will first hear from Dr. Joshua Salvin, Division Chief for Cardiovascular Critical Care, Senior Associate Cardiologist, and Associate Professor of Pediatrics at Harvard Medical School. Throughout his career, Dr. Salvin has focused on transforming complex challenges in pediatric cardiac critical care into actionable solutions. His leadership in predictive analytics, including the development and deployment of tools such as the FDA-cleared IDO2 index, has refined care delivery, enabling earlier detection of critical deterioration and improving the efficiency of healthcare delivery. Collaborating with bioengineers, data scientists, and clinicians, Dr. Salvin co-developed Raman spectroscopy technology for real-time mitochondrial monitoring, setting the stage for precision diagnostics in cardiac intensive care. Today we will hear from Dr. Santiago Borracino, who will touch on Etiometry's automated spontaneous breathing trial tools association with improved clinical outcomes, including findings from a recent study that observed a 20% reduction in post-operative length of stay and a 30% reduction in time on mechanical ventilation. Dr. Borracino is a board-certified physician in pediatrics and pediatric critical care, currently serving as Professor of Pediatrics and Medical Director of the Cardiovascular Intensive Care Unit at Children's of Alabama and the University of Alabama at Birmingham. Originally from Peru, Dr. Borracino earned his medical degree from Universidad Peruana Cayetano Heredia and completed his MPH in International Health at Harvard. He trained in pediatrics at UAB and completed his fellowship in pediatric critical care at the Children's Hospital of Philadelphia. Dr. Borracino is internationally recognized for his research on outcomes after pediatric cardiopulmonary bypass, acute kidney injury, and ECMO, with over 100 peer-reviewed publications and leadership in multi-center clinical trials. Before passing the virtual mic to Dr. Salvin, a few notes on today's format. To ensure we stay on schedule, we will hold Q&A at the end of Dr. Borracino's section. Please feel free to submit questions throughout the session. This will help us prioritize topic frequency before we reach time at the end allotted to the Q&A. With that, Dr. Salvin, please take it away.
Great, thank you very much. I really appreciate the opportunity to be here today and speak about some of our work. I'm going to talk a little bit about hemodynamic monitoring in the cardiac intensive care unit and how the technologies we've developed alongside Etiometry have really impacted our patients and how we care for children with complex congenital heart disease. So I have no personal financial disclosures, but some of the work that we did here that I'll present in these slides were funded by a NHLBI award several years ago. Just by way of introduction, this is what a typical bed space in our old unit, I'll show you our new unit in a moment, looks like. And we see just an incredibly complex environment, high acuity, low provider to patient ratio. The interdisciplinary teams, we struggle with the level of experience. There's information overload. Every single one of these devices here is streaming, sending information to the providers. These patients are changing rapidly. The physiologic changes that we see just come and go, and we need to really be on the ball about how we think about the physiology. And then there's distractions, there's alarms, there's phones, there's things that we never would have thought of years ago. And in the middle of all of this noise, in the red line here, there's a tiny baby. I mean, this is what we're doing this for, these patients. And we somehow have to be pulled back into the fact that there's a patient here surrounded by all this technology. So how do we utilize this in a way that's best for our patients? The aerospace industry really did this well and did this well many decades ago. The most, unlike the aerospace industry, though, our industry is falling behind. We have these vulnerable periods with the fewest resources, the middle of the night, the transition periods between cases coming back from the operating room and sign out from the physicians and nurses. Things that you just wouldn't see happen in the aerospace industry. Cost is a factor. It's a real factor for even in safety of our delivery models, things that you don't see in other industries. And this contributes often to the late recognition of a clinical deterioration and severe adverse events. So just by way of introduction, this is Boston Children's Hospital. I showed you a photo from our old unit. This is our new unit. And this, just to give you scope, this is our hallway and the patient rooms down here on the left. And you can see it's beautiful, it's bright, every patient has their own space, but it's isolated. So we have providers, you can see the blue scrubs down here, all the way down the hall, but we only can see certain areas of the ICU. There's these corners that we lose line of sight. We do have some central monitoring stations here. This area here is we're doing a surgical procedure at the bedside and behind those barriers for infection control. And this is what the bed spaces look like. I cut off the patient here just for privacy, but this is what the spaces look like. But you can see there's still all these devices connected to the patient. So what we've done is really trying to integrate our technology into the processes more effectively to overcome these physical barriers in the ICU. And you can see right here, and I'll show you a closer view of the Etiometry platform, is on the wall on a touchscreen display in every single room in our ICU. So traditional monitoring back in the old days, before we adopted these technologies, was that you had a bedside monitor that displayed all of the physiologic data: heart rate, saturation, blood pressure, PA pressure, the end tidal CO2. You can see there. That was inputted directly into the electronic medical record by the nurse. Whenever the nurse decided to click on something, we had a notion that it was done hourly, but if the nurse didn't like a vital sign or liked a vital sign, they could choose that. A little bit of a random number generator, as we say. And you can see this is what had happened in the EMR. You get this Excel spreadsheet, random times at the top, 2000, 2045, 2100. They're sort of periodic entries into the EMR. And then we get these graphs, and we use this in the morning. And I don't know what to make of this. This is the mean arterial pressure, but what does that really mean? Is this value what you follow? Is this value what you follow? And these are just these variable times from this chart. So not terribly useful, but that's what we relied on for our monitoring of our highest risk patients. And then in 2010, a little bit beyond that, we developed, alongside Etiometry, the T3 platform. It was developed at Boston Children's Hospital. It is a web-based interface that shows all of the vital signs every 5 minutes. Every input that goes to the patient every 5 minutes is on this display. So you can see the time on the x-axis here. You can see the parameters that are being shown here. And then each one of these tabs, I'll go through in a bit more detail, it has the ability to drag and drop onto the timeline. So you can overlay, for example, the pH on top of the blood pressure, or the PaO2 on top of the SpO2. And you can change all of those and customize those. That includes lab values, respiratory values, and other parameters. It's all touch display. You can drag the slider across the bottom, make the time frame shorter or longer as you see fit. So really went from hourly, essentially not regulated vital signs to every 5 seconds you have the real data there, giving us the first time we've actually had real information on our patients. So how much data have we collected? This is since 2010. It's sort of staggering to me, the total hours of data. For example, the 18 million hours of data. Almost, where this is actually higher. This is from earlier this year. We're approaching 800,000 patient days in the ICU that we can collect data from last year. We have ventilation data now. It's not just hemodynamic data. Dr. Borsano is going to speak a bit about that later. And then we have laboratory data in the cohort. This varies by age, but really you can see the distribution across infants compared to neonates is essentially what our census is in the ICU. But you can imagine that the neonates and infant patient population make up 60% of our data are the most frequently monitored. So we have more vital sign information for those patients. So what do we do with this? It's great at the bedside that you can walk around and see this in a visual capacity, but what I think is really important and what's impacted our patient care is the predictive analytics algorithms that have come from this. They're informed by the high fidelity data streams and the laboratory values, and there's two that we'll focus on today. There's four in total, but we'll focus on two of them today. One is the inadequate delivery of oxygen. It's called IDO2, and we'll use that term again. And then the second is the IVCO2, or inadequate ventilation of CO2. And these are real-time models that use a statistical analysis to predict the probability of IDO2 is mixed venous saturation below 40, and that's customizable, I'll get to. And the IVCO2 is a PCO2 of greater than 50. So we can utilize up to 19 continuous and intermittent data inputs to calculate the values. And what we've shown in our research is that it may actually lead to early recognition of evolving clinical deterioration. So I won't go through this slide because I'm not a mathematician. The math guys are on the call, but this is their IDO2 index. But I think that the important components of this are using the sort of Bayesian principles. All of the data that comes into the model is weighted differently. So there are vital signs that happened 5 minutes ago. Obviously, you want to weigh more than vital signs that happened 5 hours ago. And all of those are put in a screen for the noisy data, have a pretest probability of what the IDO2 of what the mixed venous saturation would be, and then it spits out a number. And I apologize for my unsophisticated explanation of that, but this is what it means in real life. The IDO2 index, if you use the full model and in the blue line here, it will show you a very high likelihood or correlation with SVO2. And the power of the model, of course, depends on the number of inputs. So if you have a patient that has an intracardiac line, an arterial line, a venous line, a temperature probe, all 19 variables that go into the model, the receiver operating characteristics are going to be a bit more favorable than if you use the minimum down here in the dotted line, which the AUC is 0.77 compared to 0.89. And the newer models, this has actually been validated in this manuscript here, but the newer models have a higher AUC as we add more variables into the model. So this is what it looks like in real life. This is the screen I showed you earlier. Again, just for orientation, the x-axis is the time. The y-axis is the parameters here, and you can see the parameters that we've chosen in this example: arterial blood pressure, the right RFP is right-sided filling pressures. There's a left atrial pressure in this particular patient. And the IDO2 index is represented across the top visually. You can also see the number if you drag and drop it into there. You can see IDO2 is 45 right here. But I would just draw your attention to the top part of the screen. Green is good, red is bad. So the higher the number of IDO2, the more red you see. And again, the higher the number IDO2 is the more likely that your mixed venous saturation is below 40%. And that 40% threshold can be represented here, and you can actually change it by clicking on this, having 30%, 40%, or 50%. So depending on the physiology of the patient, you could set the threshold for IDO2 model, which will correct itself in real time, to 30, 40, or 50%. So the important part of this, though, is that when it's green, your IDO2 is low, meaning your probability of a mixed venous saturation or low output state is very low. And you can see in this particular patient, it was red, got a bit better with some changes in inotropes, and then you see the heart rate trends start to change here, some variability in blood pressure and pulse width, and the IDO2 responds to that and got quite red. And unfortunately, right here where this line is, the patient had a cardiac arrest. You can see the pulse width gets very narrow, and the patient ended up on ECMO, which of course made the IDO2 turn green because the oxygenation was better with mechanical circulatory support. So I want to run through very briefly in the interest of time, a couple of studies that we've done. The first was looking at whether you can use IDO2 to associate or predict adverse events. And then we did find that inadequate oxygen delivery index, the dose, so the area under the curve, the more red you see, was associated with cardiac arrest risk. And I won't go through the entire study, but what we showed that even if you blind the provider to the model to the 30 minutes preceding the event, the time where you may have providers there, you may recognize that there's an impending event. Even if you don't use that, the 2 hours preceding the event with that 30-minute censored window still at a high association with the ability to predict cardiac arrest. And this is the ROC curve for that study, and you can see the ability of the model to do quite well with cardiac arrest association even hours before the event. We're not the only people doing this. Just in fairness, I think it's worth throwing out that other centers, CHOP and Texas Children's, are doing some very important work with different models. But the real traction that we've gotten with this and the advantage to the Etiometry platform is that we have been able to collaborate with other centers that use the platform, put data together in a large database, and develop more stringent models as we move forward. And this is an example of that. We pulled 5 centers together in this manuscript, and we flipped the script a little bit. We said, well, if we can tell when something bad's going to happen, can you tell when the de-escalation of care is appropriate? So we decided to look at inotropes. We said, okay, well, if we wean inotropes, when the IDO2 is high, what's the likelihood that we're going to fail, meaning we're going to need to go back on inotropes? So patient A had a successful wean, we came off, didn't go back on. Patient B down here in this panel came off inotropes and then needed to restart dopamine. And we showed in this study that the IDO2 for the 6-hour block, again, that dose, the amount of red on the screen that you saw earlier, had a real inflection point somewhere around 30 or so, that if you wean the inotropes with an IDO2 that's higher, you had much higher odds of needing to restart the vasoactive drugs. So that led to a really interesting discussion. And we all came to Boston and met for a retreat and came up with a study that was a prospective study. Again, this is our old unit. We set up iPads at every screen, and when patients met certain parameters, meaning their IDO2 was low for 6 hours and their lactate was low, we chose that as a parameter of a laboratory parameter to confirm that the oxygen delivery was adequate. We prompted the bedside provider, to wean inotropes. So can we de-escalate care safely? And we show that we know when we have to go back on, can we do it the other way? And there was no mandate to wean. There was no prescription. It was just if that flag goes up on the monitor showing that the patient seems to be in a reasonable oxygen delivery state based on those parameters, think about it, have a conversation, and think about weaning the inotropes. And what we found was that, in fact, it did make a difference in terms of the duration of infusions. So the risk-adjusted model that we created showed a 29% shorter vasoactive infusion duration in the intervention group, meaning the patients that had this monitoring device at their bedside, which is important for our patients. What we didn't show in the study was actually not powered to look for length of stay, but we did look at that length of stay and incidence of cardiac arrest or weaning failure. We didn't show a statistically significant association there, but we did show some trends towards those as well. So this is great, and we show that we can maybe figure out when bad events are going to happen and even de-escalate care, but does it improve our outcomes? And in order to really judge that, we need to understand why decisions are made. And the implementation of these technologies is really key. So putting a clinical decision support system in place is great, but it's got to be used. This has to be at the bedside and accessible. And you need to understand the workflow and the environment in the individual institution and think about how human factors go into this. And I just want to point out as I'm wrapping up my portion of this, is that when we did the trial, the clinical trial where it was suggested that patients get weaned from their inotropes. We did a pre-study interview. So we asked people how do you make decisions, how you interact with technology, and these are semi-structured interviews, and this is an ethnographic technique that links variables together. And I won't go into a ton of detail, but the size of these variables, the size of the icons there, tell you how closely linked they are. And what we found was that, oops, I'm sorry, didn't mean to skip ahead there. The technology it ends up being quite peripheral from what we do. So these technologies are fantastic. We're able to use these models or potentially use these models, but we really do need to focus on how the providers, the nurses, the physicians, the frontline team interfaces with these technologies to really get the most benefit out of them. And that's what we focused on over the last several years. We really do need to think about not just developing these models, but how do we modify human factors to incorporate the technology, like I said. So our clinical decision support tool in our case did have an impact because we have a culture where these technologies are quickly adopted and brought into the mix. But if that's not the case, or if there's not a real effort to do that, then these tools may have more of a limited impact. So in conclusion, as I wrap up, these analytics algorithms may serve as both an early warning indicator. I think the more exciting part of this is the de-escalation of care that we know is good for our patients, not good to be in the ICU. We need to think about a better framework for utilization of these tools, and then thinking about human factors as we implement any of these new technologies is really essential. So these are some of the co-authors on the papers that I presented, both in the clinical trial and the human factors work. And Peter Lawson was one of the founders of the T3 platform. So I'm indebted to him for supporting a lot of this work as well. And I will stop there.
Thank you, Dr. Salvin. I want to quickly provide a quick intermission for those who have recently joined. I want to remind everybody there's a Q&A button up in the top of the screen where you can submit questions so that after Dr. Borsino's section, we can prioritize those and get those up. So with that, please take it away, Dr. Borsino.
Good morning. Thank you all for being here, and thank you for Radiometer for the invitation. I want to touch on a few things. I want to show you some research we've done with multiple centers who use Etiometry, led by Boston Children's, and also show you an experience we had with using Etiometry not only as a platform for risk algorithms, but also as a way to help the bedside people to perform tasks and make decisions regarding ventilation and extubation. I don't have any disclosures. I wish I had a grant. I don't. So first, I want to talk about the two newly published papers on extubation failure that we've done using Etiometry as a platform, not only of the indexes, but also as a way of doing research. And I think this is another big part of it, that we were able to get a lot of data out of Etiometry to be able to evaluate the extubation success and failure, and also through getting 8 centers who have Etiometry together to be able to build this study as big as it was and as detailed as it was. It was a retrospective study. It involves 8 centers. We included in the first paper was about neonates. We wanted to separate neonates from the older kids. And the reason why we think this is important is because in cardiovascular surgery, the failed extubation is not only due to respiratory variables. You can have upper airway obstruction, you can have lung disease, you can have weakness, you can have oversedation. Those things are shared with the general pediatric ICU, but in the cardiovascular unit, you have to sort of add the effect of taking the ventilator off and cardiopulmonary interactions and how much the ventilator helps the patient with oxygen consumption in your calculation decision making to extubate and what's going to happen afterward. Now, the other thing that is also true is that our patients tend to have a lot less reserve, especially if they have a lot of heart failure. So the risk of cardiovascular collapse and cardiac arrest is a lot higher in our population than in the general PICU. So the decision making around extubation makes sense that it will include some way of knowing if during the period close to the time of the extubation, you're having cardiovascular problems. So we thought this was perfect. Also, another one was which is the other index, the index that tells you the prognosis of how high your CO2 is also knowing about the time without having to do 1 minute gases to get an idea of how the ventilation of the patient is doing right before you're going to take the tube out. So what we did was this retrospective study of neonates who were ventilated for more than 48 hours after the surgery. We did exclude some patients because we wanted a clean study. We don't want to get patients who were premature, who were really small, who died before the extubation, or who had a withdrawal extubation. We didn't want unplanned extubations, and we didn't want to include as extubation failure somebody who had failed extubation, who was intubated for a procedure, let's say, you needed to go to the cath lab or a chest tube or back to the OR for a clean out. So we did exclude those, and of course, tracheostomy. Our primary outcome was extubation failure, and this was defined as extubation within 48 hours of the extubation. And our primary exposure was to see if the IDO2, this algorithm calculation of prognosis of having SVO2 below 30 for the single ventricles and 50 for the biventricular patients was going up above 5% or above 25%. And the IVCO2, the index that shows you have a higher CO2 than 50, above 50%. And of course, things are complicated in our world, so we needed to do a multivariable analysis. We did try to use center effect, but at the end we realized that center effect was not that important, so that was not part of the variables chosen. As you can see, one of the things that I highlighted before is the power of doing research with Etiometry. We were able to do a study with 8 centers and 336 patients. Most of the patients did not fail extubation. Our extubation rate was about 14%. Most of the patients had high complexity surgeries, stat 4s and 5. There was a significant amount preoperative respiratory support and preoperative mechanical ventilation. The patients, as neonates often do, stay for a long time, but you can see here what we found in many other studies. The patients who failed extubation tend to stay in our ICU more, tend to have cardiac arrest, and have a higher risk of mortality, and those are unadjusted. So what did we find once we introduced the model? We did 2 models. One model was without the indexes, so that model included all the patients, and the usual suspects were there: preoperative ventilation, mechanical ventilation duration, single ventricle, and stat 5 procedures were in the model, with preoperative respiratory support being the one that was significant. In the model 2, we excluded the patients that didn't have a complete set of Etiometry data for calculation, so it was a little bit limited at 478 patients. And in this one, we found that single ventricle and the index either higher than 25% or higher than 50% chance of having low cardiac output or inadequate or high CO2, both were associated with extubation failure. So this study sort of points in that direction, that adding a tool through algorithm calculation that tells you what the patient's cardiovascular state is, and maybe having every 5-second guidance of what the CO2 is doing in the background could help us in the decision making for extubation. These are the hazard curves, and you can see there's clear separation of the patients. This is on the This is not a hazard with multivariable analysis. This is just single variables. But you can see the separation is pretty clear between those patients who successfully extubate and those who didn't when you look at their IDO2s. So this is important work of adding to our usual vital signs and how the indexes can help you second to second. The second study is basically the same, but we wanted to see how it will work for the older kids. Etiometry T3 stops at 12 years of age, so that's why we stopped. We went from 1 month to 12 years. Similar exclusion criteria, same outcome, same primary outcome, same exposures, and of course a multivariable analysis because we do this. Our patients are different. This one was a little bit larger study, same centers, up to 922 patients. The extubation failure, of course, in the older patients is a little bit lower. So, but we still found the same outcomes. Extubation failure is associated with bad things. So when we did the multiple logistic regression, we had 3 models, and depending on the numbers of patients. But the one that I want to highlight is the third model where we included the risk analytics algorithms, and we can see that in this one, the risk analytic of pre-extubation IDO2 more than 5 or IDCO2 more than 50 were associated with double the risk of extubation failure. In the other models are the usual suspects, and one that is very interesting because it's something that we do more and more and more. This is sort of outside of Etiometry talk and AI talk, is nitric oxide. We've gotten really comfortable extubating patients from nitric oxide, but those patients are risky, probably for more reasons than one. So it's important to me, that was an important finding of our study that not a lot of studies have been able to show. Same thing, when you look at the hazard curves, unadjusted, there's a clear separation when you use the cutoffs of the that we use for the IDO2. Patients who show cardiovascular compromise with the IDO2 or higher CO2 with the IDCO2 tend to fail extubation. So this is how the indexes could potentially help us. But what else can the platform do? In Alabama, we were interested in the platform because of the possibility of automating things, of having the platform do things in the background for you, collect data and show it to you in a way that could help you make decisions. It also is a very powerful platform to automatically create flags, similar to the weaning of the inotropes. The idea being is that the Etiometry platform can know when you're changing the ventilators, when you're getting to certain ventilator settings, and it can help you trigger or improve algorithms that you already have in your unit. So what did we do? We wanted to see if creating an algorithm will help us extubate patients. And once we put it out there, we were curious about what kind of an effect we were going to do. So this paper that was published for us looking at before we had the algorithm embedded into our Etiometry, we'll call it a map application, and after. And we wanted to make sure that what was going to happen to the extubation failure rate to make sure that it didn't change. Our concentration was on both what it took to trigger when the patient arrived to extubatable settings, and also a tool that would allow us to see the spontaneous breathing trial in a way that will help us make decisions based on data. A little bit of information about our unit. We do have a very complex looking extubation weaning protocol run by the RTs. Once the patient is doing good, we tell the RTs to go and they wean the patient down to the ventilator setting. This has been very useful. This is not data or scientifically proven algorithm, but it works for us and it makes our life very easy. We don't have to talk about weaning. The respiratory therapists do it for us, and it's great. But this is the setting that we use to do this trial, to do this before and after experiment. this algorithm already existed for both periods. So this was not new to either one of the periods. So we wanted to create the flag. So this was the first process. And the first process was easy because we already had a sort of very, very standard way of deciding if somebody was ready to extubate. The PEEP needed to be 5 or sorry, less than 6, 5. The rate needed to be 10, so this was less than 12. The pressure support needed to be 10, and the FiO2 needed to be 60. So those are the triggers that made them, that were embedded into the algorithm to say, hey, a yellow flag will appear and say, hey, this patient is ready for a spontaneous breathing trial. And this was very useful for our respiratory therapists and for us, and we have this place in every bed. So hopefully this will help people remember to get the patient extubated. The other thing we did is we wanted to create an algorithm similar to the algorithm that we use for IDO2 and IDCO2, but limited with the amount of information we have. This was a single center, so this was a lot of less patients. We were limited in some ways. We didn't have the weight, and I was very against the idea of having to introduce any kind of new data into the model manually, because I knew that us humans were going to forget. So we did not include weight, so there's no minute ventilation per kilo or tidal volume per kilo, which would have been extremely interesting. The other thing that I wanted to make was an algorithm that will work at any age. So we decided to use the patient comparison. So we will compare the patient before they started the spontaneous breathing trial to their variables during the breathing trial. And what we were looking was for change. Is the patient worsening during the breathing trial by a certain percent or by a certain number? And all of these numbers here in this list we came up with them just from experience. And the idea was, let's compare the patient to themselves at a rate of 10 compared to you don't have a rate, you're just pressure supported. And all of this would allow the machine was all of this was detected by Etiometry that it was happening and automatically was calculating the numbers without us having to do anything, without no request. You will get it for every single spontaneous breathing trial. Once we did the calculations, we came up with these variables that were associated. Unfortunately, we didn't have enough power to include the IDO2. Well, the IDCO2 at the time didn't exist yet, and the IDO2 didn't reach significance probably because our N was very small. But this is the algorithm we deployed. This is the view of that is created by the platform for a breathing trial. Basically, what it does is it shows you the whole breathing trial, and this, I think, is another advantage, because a lot of times in the old school, you will put a patient in spontaneous breathing trials, and the respiratory therapist and the nurse will call you, hey, this is the end, the patient did good, but you have no way to be there for the whole hour. So the platform in this way will show you the whole hour, and you can actually see when the patient dropped their blood pressure, when the patient dropped their pulse ox, when the patient's end-tidal CO2 was higher, and it will help you in your decision making. It would also calculate a percent of time the patient was outside of those parameters. And you can see here with in a diagram, the red little dots are the times when the patient was violating the parameters, again, comparing itself with itself before the spontaneous breathing trial happened. And we divided into groups, less than 24% of the time within goals, 25 to 75, and then more than 75 as sort of like natural cutoff points of when the patient will have higher risk for extubation failure. We did it in our unit. We did it between 19 and 23, and our goal was to look at total time of ventilation, time to first extubation, length of stay, and of course, we didn't want our extubation failure to worsen. This many patients had surgery during that time period, and so 580 pre and 200 post. This is a comparison of the periods. The periods were sort of comparable, but you can already see in the outcomes part at the bottom that our length of stay was slightly shorter in the post-intervention period, and this is without any adjustment. but not the total ventilation time, at least without adjustments. When we did adjust and we included prematurity, presence of a syndrome, and the stat category, we kept the model simple because again, our N wasn't huge. And we found that after the deployment of the algorithm and the flags, we were able to decrease our ventilatory time by 30% and our post-operative length of stay by 20. Failed extubation was actually less. Sorry, this is and going back. Failed extubation did not change. We were also interested because the neonates are different and are more complicated. And yes, this was a much smaller cohort, but we were interested in look at it separately. Interestingly, we didn't have any extubation failure. It's only 33 patients. That may be a little bit of luck. And then the other one is that what we saw here was the total postoperative time was decreased by 33%, but the others did not show any difference. So we were able to show some improvement with the neonates. And this is a univariable analysis. So why it is important? Of course, showing a reduction like this will be awesome, but the caveat is this is a single center study, and it's a before and after. And unfortunately, at the time, we didn't have the bandwidth to really measure how often people were using. And going back to the diagrams that Dr. Salvin was showing us, that a lot of this technology works if people use it. So before and after, not the best science, but I think it sort of showed that this technology can be tapped in this way, where you can improve the visualization of a spontaneous breathing trial, that you can add algorithm calculations to that breathing trial to aid the physician, and you can use a display to remind people that a patient is ready for the next step, which is important and similar to the discussion about weaning of the inotropes that Dr. Salvin showed. So I think in general, this showed that there's potential here, that this can be tapped to improve patient care, to accelerate patient care. And I think that more studies are needed, and it will be extremely exciting to potentially do this with more data, potentially include the IDCO2. These two studies sort of were happening. The two first studies and this study were sort of happening at the same time. So we didn't have all the data to be able to include the IDCO2 and the SVCO2, sorry, IDCO2, IDO2 and the IDCO2 into the model, which would have been great, but we didn't know at the time. So thank you so much for the attention, and I go with, now we can do some questions.
All right. We can now start the Q&A session with the time we have left. Also, we can follow up with questions we do not get to offline, but I've already seen a few come in, so I will get started on those. So for Dr. Salvin, you mentioned involving staff in understanding AI tools and iPad usage. How critical is it for staff to not only know how to use the technology, but also understand the information being shared in terms of improving patient outcomes and overall success?
Yeah, it's a really, really important point. I think anytime you're trying to change culture or change behavior, you really have to give people the why. And so we've been fortunate here as we develop the technology alongside Etiometry that people saw this, we all saw it grow up. So we saw the platform evolve from a web-based interface that shows some vital signs to the ability to drag and drop parameters to what we use now. So it really got ingrained in our culture early on. But when we do things like create a clinical trial or think about how we're going to utilize these for weaning or for recognition of events, it's a great point that I spent a fair bit of time alongside others in our team doing education with the nursing staff, education with our trainees, our respiratory therapists. They were all involved in these processes before we rolled any of this out. So in the months and year actually preceding the clinical trial, we told people why we're doing this, what our hypothesis is, and encourage people to interface with the technology. It didn't mean that they had to actually follow through with that or make any changes in their clinical practice, but it was just the interface with the technology. But it is really, really key to establishing that into our workflow is to do the education in advance. And I encourage anybody that is thinking about adopting this technology to do exactly that.
Can I, Anthony?
Yes.
Can I say something? I think everything he said true. I think also you need to consider design, where you put it, where you put the screen, how easy is the screen to use. If you're going to use a touch screen, how sensitive or not sensitive, a good quality touch screen, because the more barriers you create to the usage, the less likely is they're gonna think to use it unless they see an amazing benefit. The other problem that we have is there's a lot of turnover of staff. And a lot of times when you're new, and we all remember when we were new doctors, when you're in survival mode, you don't get to think about extra things that can help you. You just want to get your shift done. And a lot of new nurses just don't have the luxury of like getting to the point where they're so comfortable in the unit where they start like thinking about, okay, so how can I do the next thing, which is the use of a tool like this instead of just being in survival mode. So that definitely affects how you deploy a tool like this, but don't minimize design, don't minimize the quality of the interfaces that you put, screens in multiple places, and of course education, and try to encourage people to get the why. The why is what drives us. We do things because they're going to help our patients, so they're going to help ourselves. And that sounds selfish, but it's true.
And just building on that for one more point is I totally agree that the placement of these devices is critical. And I don't know if we made it clear that this is a web-based interface, but the touchscreens, for example, the bed spaces have what we call persistent displays. If you walk to bed space 30, you can only see patient 30 there, and it's just easy. You don't have to log in, you don't have to change the number of the bed space that you're at. It's always going to show that particular patient. So it takes down those barriers, those sort of entry barriers, and the momentum that you need as a new faculty member, a new nurse, to go log into the system. The other part of it, though, which I like to do, I carry my iPad everywhere. So I use the same interface just on a Safari browser on my iPad and do the same touchscreen open and close, and I can walk between bed spaces with a little bit more experience and say, okay, I'm going to click on the next patient and do that. So you really do have the option. But if you're trying to drive adoption, make it as simple as possible. The younger generation, I will say, they're very technology savvy, and that they've grown up with sort of the instant gratification of being able to walk by and see something without any barriers to the interface. And that's, I think, what's been a huge part of the adoption here is getting the younger, newer crowd invested because of how easy the interface is to use.
Thank you. I'm going to go on to a next question, which I think, Dr. Borson, you might have touched on a bit after this question was submitted, but I just want to make sure we cover it. In your study, did you use standardized ventilator settings when initiating mechanical ventilation? If so, what were those standards and what was the rationale behind them? Additionally, how did you manage ventilator adjustments? Did you follow a consistent protocol with specific criteria or weaning for escalation?
So the initial ventilator settings are usually the ventilator settings that are set in the OR for our postoperative patients. Common things are common. Most of our patients don't have severe lung disease, so they're somewhere between 6 and 8 millimeters of tidal volume per kilo. The rate, whatever rate that needs to be started for control of CO2, PEEP 5 if there's no lung disease, and FiO2, 40%. There's no real standardization. I'm just saying that because common things being common, that's what almost all patients get. The adjustments up when the patient is sick are not standardized. They're done in conjunction and discussion between the respiratory therapists and the physicians and the nurse practitioners. What we have is once the patient is doing well and we decide, hey, this patient is ready to extubate, then we activate the weaning protocol. So the weaning is protocolized, how the rate is decreased, how the FiO2 is decreased, to the point where we go to what we call minimal settings, the PEEP of 5, rate of 10, pressure support of 10. But the initial vent settings are not standardized. Are basically whatever the anesthesiologist thought the patient needed and on arrival to our unit.
Okay. Another question just came through. Your idea of integrating a centralized respiratory therapist monitor in ICU, NICU, and PEDS departments supported by AI technology is strongly aligned with emerging trends in critical care and respiratory therapy. Research increasingly supports the concept that AI-enhanced centralized monitoring can improve communication, streamline workflows, and elevate care quality. What is your opinion?
Yes, and I wish I was able to tell you that what happened in my unit with the improved outcomes was solely because people were using this app like crazy. But we did put a screen in the respiratory therapist workroom. We did all the education. We encouraged them to use it. The flags are. I wish they were bigger in the surveillance mode of Etiometry. That will be a little bit easier to see them, but they're visualized. And I totally agree. I think that a lot of the problems that we have with weaning is not that the patients aren't ready, is that we forget to do it. I think that a lot of the studies on extubation readiness have proven that the patients are ready to extubate faster than we think they're ready. And I think the same is true for inotropes and for weaning of the ventilator, etc. I think that having something automated that reminds you to do it or do it on a clock, on a schedule, will get our patients liberated from the ventilator and liberated from inotropes faster. Once they start getting better, we're not fast enough. Not for all patients. And this is where this technology could be really, really helpful because it can help you avoid the mistake of weaning somebody too early, right? If the IDCO2 is high, you don't have to get a gas. You start seeing that, and maybe this is the patient where we stop. But I think that the patients where we need to stop are the minority, not the majority. And I think that everybody gets affected and stays longer in the ICU because we're afraid that we're going to miss somebody. So technology like this could be the difference in helping us weed between those who are ready and should just go, and those who you need to be patient with.
I know, Dr. Salvin, we will lose you in 2 minutes for back to patient care. So I just wanted to ask one more question before you leave us. We mentioned now respiratory therapy and nursing. Was there any formal committee formed when implementing any pieces of the platform or the whole thing? If so, what were the key stakeholders of that?
Yeah, it's funny. The way we did it, because the technology was a little bit homegrown, it became kind of ingrained in our culture early on. But as it really spread and we moved to this new unit and put up these displays, we had clinical champions. So it wasn't a formalized committee, but we had clinical nursing champions particularly. There were, I think, 10 or so folks that were really technology savvy, very interested in bringing this forward, and work with the nurse educators on the unit to put the pieces in place around education. So Etiometry helped us with that as well, in terms of creating use cases that we could use for demonstration purposes. We didn't get into this at all, but you can click on a particular patient and a time frame, like where this cardiac arrest is, and on this example, and use it as a teaching case. You can show nurses, fellows, physicians later on that, hey, this is where the physiology may have changed. This is something we may have responded to, and start to, again, show people the why, show people how this can be useful. So not so much a committee, but really having champions that believe in the platform, that work with our educator group, And then as that happened, interestingly, the nursing staff, for example, adopted this. This is a much easier way, if you click on a 12-hour view of a patient, to sign out a patient at 7 p.m. for our nightly handoffs with the nurses. They were able to say, okay, these are the inotropes the patient's on, these are the blood pressures and heart rates trends that have been going on throughout the day, rather than have handwritten notes. So that it became a bit organic in terms of adoption. We use it for our attending handoffs at the end of the day as well, for the same in the same manner. So it really did start as a homegrown, led to people adopting and champions education, and then as it became part of our daily workflow, it really, at this point, I don't think anyone in our unit remembers not having the platform and not being able to utilize this technology. But I hope that answers your question.
Yeah, it makes sense. Not so you didn't need a formal committee, but champions are key. Yeah.
Really critical, especially when we moved units and the physical space was different and the displays went up. We did not have those displays before. We relied on the iPads at the bedside, and that really kind of, especially for the newer staff. But here you go. It's right in front of you. It's super easy to use. No login, no barriers, and so getting that word out there was key.
Okay. Well, we'll let you go, Dr. Salvin. Thank you so much.
I really appreciate the invitation. Thank you very much.
Yeah. And so for the rest of us, thank you all for your time and attention today. And another special thank you really to Dr. Salvin and Dr. Borsino for sharing their work with us. Please reach out if you would like to learn more about the Etiometry platform. We're always happy to schedule follow-up demos. And with that, today's webinar is now concluded, and please have a good rest of your day.